Thank you very much. So as the first two sessions about assessing risk and advising people who can fast and who cannot fast, and now we come to people who have already decided that they're going to fast and how can we help them. So Dr. Khadija will cover patients treated with insulin, and my part is to cover those treated with non-insulin therapies. So this is issues I'm going to go through. So Ramadan focused education, Dr. Khadija has already alluded to that, but I'll give some more details about that. Lifestyle is important, and then I'll go through the medications, the different medications, non-insulin medications, and how we adjust them in Ramadan. And these are the two questions I showed earlier. So we have addressed the first question about assessing risk, and now we are addressing the second question of how we can help people to fast as safely as possible. So as Dr. Khadija mentioned, a pre-Ramadan medical assessment is important, and that should have happened by now because Ramadan is just a few days ahead of us. So this generally about between 1 to 2 months before Ramadan, we should do that. What we would do in that assessment is to assess, first of all, assess glycemic control, looking at their hemoglobin A1C, looking at their results of self-monitoring of blood glucose at home. Risk of hypoglycemia is very important. As we showed earlier, the main worry during Ramadan is we want to avoid hypoglycemia. We check them for comorbidities, so especially renal, cardiac comorbidities and other comorbidities. And later on this afternoon, we're going to have sessions on looking at the issue of fasting at Ramadan in people with renal problems and with cardiac problems. As Dr. Khadija mentioned, also experience in previous Ramadan is important because it can actually guide us on what is likely to happen in this Ramadan. And also, of course, we need to keep in mind if there are any changes in medications that have happened since last Ramadan. And of course, structured education is the key. So what are the elements of the structured education pre-Ramadan? Well, we went through risk quantification. That's part of the education. But then self-monitoring of blood glucose is really important. Most people with diabetes, especially those who are treated with insulin or sulfonylureas, we advise them to monitor glucose outside Ramadan. But in Ramadan, it has really special importance. So those who don't monitor before Ramadan really will have to get the message that they should monitor in Ramadan if they're going to fast safely. So they should monitor, but also we should give them very clear instructions on what to do with the results. So we should give them clear instructions on what sort of levels, when they see those levels, when they should break their fast. Lifestyle advice is important. So exercise, fluid and diet, and of course, the issue of adjusting medications. We'll go through that in a little bit more detail. So we talked about risk quantification. Now, the role of self-monitoring of blood glucose, as I said, for people who are on insulin, this is really critical. They have to monitor. And especially in Ramadan, it's really very important because of the risk of hypoglycemia. So it's critical for people who are on insulin, but also for those on sulfonylureas because of the risk of hypoglycemia. It's also important for them to monitor during Ramadan. We should, as I said, we should give them advice on the timing of when they should monitor, and also what action to take if they reach certain levels. So this is the guidance from the IDF DAR about the suitable timings for doing the monitoring. But perhaps if someone is not willing to monitor much, if they are asked for particular times when they get the most information, perhaps the time, maybe the hour or so before iftar. That's the time when the risk of hypoglycemia is highest. And that's a suitable time to check. Another time, which is also gives you quite useful information, is about 2 hours after iftar, because that's the time when the risk of hyperglycemia is high. So if for someone who wants to monitor just maybe twice, these are probably the best times. However, it's also very important to remind them that if they feel symptoms, they should check anytime. So if there is impending symptoms of hypoglycemia, feeling dizzy, feeling blurred vision, and so on, they should really check straight away to confirm whether they have hypoglycemia or not. Okay, so that's monitoring, and we should give them, as I said, very clear instructions on when to break the fast. And again, this is based on consensus of expert opinion, these figures. So we should really advise people to stop, to break their fast if the glucose is less than 70. Even, as Dr. Khadija mentioned, even if it's just like an hour before iftar. Because, especially for people who have taken insulin or taken sulfonylurea, it can actually get lower, and that can actually be serious. So when they reach 70, they should break their fast. And this is a medical opinion, but also strongly backed by religious opinion, because لا تلقوا بأنفسكم للتهلكة. It's serious if they continue to have hypoglycemia, and it can get worse. If they get a level of glucose of between 70 to 90, we generally advise them to check it again in about an hour, and to see if there is a trend, if it's trending down. And if it is trending down, then they should break their fast, because this is likely that it's going to get worse with time. So if they reach 70 or going less than the previous level in an hour, then they should break their fast. Hyperglycemia, the cutoff level chosen by the consensus group is 300. So when people reach 300, we should advise them to stop fasting, break their fast straight away. Why? Because hyperglycemia can actually get worse, and dehydration can be serious and can cause problems. And also, very importantly, if they are not able to monitor for some reason, if they feel symptoms of hypoglycemia, so feeling very dizzy, feeling shaky, then they should break their fast straight away. If they are able to monitor, fine, but if not, they don't have a machine close by or something, they have symptoms, they should break their fast. This is medical opinion, and this is also a religious opinion. They should break their fast straight away. Okay, so that's when to break their fast. And then lifestyle, so exercise. So people who do exercise outside Ramadan, they don't have to stop exercise in Ramadan, but we can advise them to do it the proper way. So if it's gentle exercise like walking, that can be done actually before iftar. Asr time, that's okay, it's allowed. However, if they are worried about hypoglycemia, or if they want to do some more vigorous exercise, then that's better than after iftar, because of the worry about hypoglycemia. So roughly about 2 hours after iftar, if it's going to be vigorous exercise, going to the gym and so on. And again, as Dr. Khadija mentioned, Tarawih prayer can actually be considered as part of the daily routine of their exercise. So they can keep that in mind. Okay, so that's about exercise, about fluids and meal planning. Again, this is important. And it's important to remind people that the rules about healthy diet in Ramadan and outside Ramadan, the same rules about taking a healthy diet. So it's the same principles. It's important to advise people that there is a tendency for people after long hours of fasting to overeat in iftar, and we should try to discourage them from doing that. We, as much as possible, the main meal in iftar should contain some complex carbohydrates, because they raise the glucose level gently rather than very acutely. Taking vegetables and other fiber-containing foods, again, is very helpful, because that increases the glucose levels gradually. And as Dr. Khadija mentioned, there is lots of Vimtos around and lots of sugary drinks now, and we should really try to discourage people as much as possible against sugary drinks in iftar time. Okay, dates are obviously a very important part of the iftar. You cannot avoid them, but we can tell people maybe up to 3 dates are allowed. More than that, probably they will increase the glucose too much. So up to 3 dates may be reasonable. Fluid intake is really important. So non-sugary fluids, because of the long hours of fasting hours. During the non-fasting hours, we should encourage them to drink as much fluids as possible, obviously non-sugary fluids, to keep them hydrated during the fasting hours. Sahur meal should be delayed as much as possible. So this is a good practice from a health point of view, but it's also sunnah as well to delay sahur as much as possible. So if you delay it, that will give you some extra calories during the daytime. And as much as possible, taking complex carbohydrates in sahur is helpful. And also, some people take proteins in sahur, and that's actually very good, because it again raises the glucose gently and can stay longer in their system to give them enough calories during the fasting hours. Okay, so that's about diet. And then the issue I'm going to spend more time on is adjustment of medications in Ramadan. And before we go to the details about the adjustment of medications, I'll just go tell you about a survey that has been done in the recent times. I showed earlier in the first talk the EPIDIAR study, which was a survey done in 2001. So the IDF-DAR group felt that That's 20 years ago. We need a new survey because lots of changes have happened with management of diabetes over the last 20 years. So this survey was done in 2020 and 2022 as well. So again, a large survey, nearly 15,000 patients with diabetes and across 14 countries. So from the Middle East and North Africa region, from some Asian countries, and also some 2 European countries, Turkey and UK. The results of this survey are still being analyzed, but Dr. Hassanin provided us with some information about this survey. So obviously, as expected, the majority are type 2. 84% of them are type 2, but quite a good number of type 1 patients, 2,300 patients. The median age was 51 years. And looking at the medications, obviously, this is across several countries. These are the medications used by people in Ramadan. So obviously, as expected, metformin is the most widely used medication. 80% of people use metformin, safe drug, and used quite a lot in Ramadan. Any insulin was used by 44% in this survey. Sulfonylureas are still used quite a lot. Nearly 40% of patients are using them. The DPP-4 inhibitors are used by about a third of patients, so they're used a lot. And the newer drugs, the SGLT2 inhibitors, are also becoming more popular now. So 1 in 5 people are actually using SGLT2 inhibitors now in Ramadan. The other drugs are not used very much. TZD like pioglitazone and GLP agonists, only 4 and 3%. So not used very much. I think in the case of the GLP agonists, that's mainly because of cost issues. Because when you saw the list of countries there, a lot of them are low and middle income countries. So GLP agonists are expensive drugs, so they are not used very often. Okay, so these are the medications we'll go through. So these are the non-insulin medications. Metformin is the most widely used, and then the others. And I think the general principle, again, as Dr. Khadija mentioned, individualization is the key word here. So we're not giving the same advice to everybody. We individualize the advice according to that patient's particular circumstances. And we individualize the advice depending on these factors. So the pre-Ramadan diabetes control, we look at their A1C, we look at their home glucose monitoring and so on. Risk of hypoglycemia is really crucial when we think about adjusting the medications. We want to avoid hypoglycemia, but at the same time, we don't want their glycemic control to deteriorate a lot. We don't want hyperglycemia. And again, as we mentioned, their experience in previous Ramadan is actually very helpful. It tells us what worked before and what might not work this time and so on. Okay, so one of the studies that actually helped with our advice with adjusting medications was this study done in our institution in Imperial by my colleague, Dr. Nabil Ihsan and colleagues. So basically what they did was they looked at a large number of people with diabetes and they did continuous glucose monitoring on them. They did it before Ramadan, which is shown in the blue color there. And then they did it during Ramadan, which is shown in the red color. So this is the result of the CGM. And this is obviously, the lines show the mean for this big number of patients. And one of the main messages from that study was the time before iftar, as you can see, the red line keeps going down and reaches the lowest point just before iftar. So there is a tendency for hypoglycemia before iftar. And we need to keep that in mind when we are advising people about adjusting medications. And also what was shown is that after iftar, because obviously people have been hungry and sometimes taking a big meal and drinks and so on, and there is a tendency towards hyperglycemia post-iftar, roughly about 2 hours post-iftar. So there is pre-iftar hypoglycemia, tendency towards that, and there is a tendency towards post-iftar hyperglycemia. So we need to keep that in mind when we are advising them on adjusting medications. Okay, so starting with people who are on diet, not on any medications, how do we advise them? And really, these people, their risk from complications is very low, so they can fast safely as long as they don't have other problems. So the main advice we give them is that just to avoid overeating in iftar, to avoid the hyperglycemia after iftar, as we saw in the CGM record there. And we generally advise them also to distribute their calories into about 2 to 3 meals. So maybe two main meals, iftar and sahur, and then a snack maybe in the middle. And by distributing the carbohydrates between these 2 to 3 meals, that will make the glucose levels steady and not go too high. So that's for diet controlled people. So going to the medications, I'm starting with metformin, the most widely used drug. For each of these drugs, there are some studies have been done, and for some of them, no studies have been done. if there are studies, I will just select some examples of these studies. Metformin has been considered very safe, and this is why no studies have been done, because everybody agrees it's a safe drug for fasting in Ramadan. So no randomized controlled trials have been done on metformin in Ramadan. However, all the other studies, for example, sulfonylurea and DPP-4, they are on top of metformin, because most people take metformin plus something else. And overall, I think it's agreed that the risk of hypoglycemia is low from metformin, so it is generally considered to be safe in Ramadan. So how do we advise people to take their doses of metformin in Ramadan? Well, if they take once daily metformin, then we would just say you don't need to modify the dose and just take it at iftar time. Some people take metformin twice a day, and again we tell them that's fine, you just take it the same, so no dose modification, and take one at iftar and one at sahur if they take it twice daily. Some people take metformin 3 times a day outside Ramadan, and what we would advise them is that they take their morning dose at the sahur time, but to combine the other 2 doses and take them at iftar time. The total dose will remain the same. Some people take the modified release form of Ramadan, and this is usually once daily, and they just, again, no dose modification, you just take it once daily at iftar time. So that's for metformin. How about sulfonylureas? Well, some studies have been done on sulfonylureas. I'll just show an example of one study. So this is a study published in 2011, 1,378 patients with type 2 diabetes. This is an open label observational study. And the main primary outcome from this study was symptomatic hypoglycemia. And they looked at the number of sulfonylureas used in this study. And the main result from this study was, yes, hypoglycemia did occur, but it's less with gliclazide compared with, and gliclazide was less than glimepiride, and both of them are less than glibenclamide. Okay? So the main message from this study is not all sulfonylureas are the same. Some of them have more risk of hypoglycemia than others. Glibenclamide is the one that's most guilty of hypoglycemia, and as much as possible, we should try to avoid this all sulfonylurea because the risk of hypoglycemia is high. The risk of hypoglycemia with the other SUs, the modern SUs, is less than glibenclamide. So how do we advise people to take the sulfonylureas in Ramadan? Well, if they take it once a day, we just say take it at iftar time. However, if their pre-Ramadan control was very good, their A1C is target or close to target, then we could consider actually reducing the dose because we want to avoid the risk of hypoglycemia. So we would advise them to reduce the dose. So for example, if they are on glimepiride 2 milligrams, we would say take 1 milligram to reduce the risk of hypoglycemia. For those who take it twice a day, we would advise them to take the main dose at iftar time, the same dose, not changed, but the dose taken with sahur time, they can actually reduce it by, generally we say about half at sahur time to reduce the risk of hypoglycemia during the fasting hours. And as I mentioned, if someone is on the old sulfonylurea like glibenclamide, because this one carries a high risk of hypoglycemia, that really should be, if possible, changed to the less risky sulfonylureas like gliclazide MR or glimepiride. Okay, so that's the sulfonylureas. How about the DPP-4 inhibitors? Well, a number of studies have been done on the DPP-4 inhibitors, and I will just choose some examples. So this was a study, an open label randomized control trial, 1,066 patients. This is led by Dr. Saud Sifri from Saudi Arabia. And these are patients treated with either sitagliptin or sulfonylureas. And the outcome was the risk of hypoglycemia was actually significantly decreased on the sitagliptin compared to the sulfonylurea, reduced by almost half in this study. Again, another study, again, open label randomized controlled trial, 870 patients done in India and Malaysia, and treated with sitagliptin or sulfonylureas. And again, the risk of hypoglycemia is significantly reduced with sitagliptin compared with the sulfonylurea, almost half. Some other studies have been done on other DPP-4 like vildagliptin, and again came to the same conclusion. The risk of hypoglycemia is less when you compare them to the standard treatment, which is sulfonylurea. And this is what the DAR guideline came up with. So they said DPP-4 inhibitors are generally safe drugs in Ramadan for a number of reasons. First of all, risk of hypoglycemia is low, but also they are taken once a day. They maintain good glycemic control. They're not associated with weight gain. So generally, they are safe drugs to take in Ramadan, and the dose should be taken the same with no change because they don't cause hypoglycemia. So they don't require any treatment modification during Ramadan, the DPP-4 inhibitors. Okay, how about the SGLT2 inhibitors? Again, some studies have been done on the SGLT2 inhibitors. These drugs are becoming more popular because they have other benefits on kidney and heart and so on. So this is one example of one study done in Malaysia. So 110 patients with type 2 diabetes. Here they used dapagliflozin, one of the SGLT2 inhibitors, compared it with the standard treatment of sulfonylureas. And the risk of hypoglycemia was less with the SGLT2 inhibitors compared with sulfonylureas. However, there were a little bit of postural hypotension, some urinary tract infections with dapagliflozin, but not statistically significant. So that's dapagliflozin. Another study was done with another SGLT2 inhibitors, canagliflozin. 321 patients, and again, the hypoglycemia were less with the canagliflozin compared with the sulfonylurea. Patients in both groups actually fasted Ramadan safely with no problems. There were, again, a few episodes of volume depletion leading to a bit of hypotension and a little bit of dehydration with canagliflozin, but no major problems. So overall, the assessment of the DAR guidelines is that the risk of hypoglycemia from the SGLT2 inhibitor is low, is very low. They can be taken at the same dose, taken at iftar time. However, we have to be cautious with some groups of people. So the elderly, people who are on diuretics, there might be a little bit of risk of hypotension and dehydration, and we need to be careful with these people. But otherwise, these drugs are safe and can be taken in Ramadan and have been used widely in Ramadan with no major problems. Okay, next drug to talk about very briefly is pioglitazone. Again, no studies have been done. However, from the mechanism of action of this drug, it's considered to be safe because it does not cause hypoglycemia. So the risk of hypoglycemia is very low, and it's taken once a day, so it can be taken at iftar time. So people who are on pioglitazone can continue the same on the same dose because there are not usually issues with Ramadan. And then the last group is the GLP receptor agonists. And I did show earlier that in the survey done in many countries, the use of GLP agonists is low. However, actually for us here in UAE and in the Gulf region, they're actually used quite a lot and becoming very popular, mainly because of the weight benefits. So these drugs are used a lot. And we have lots of people actually taking them during Ramadan with no major problems. And these are the available GLP agonists, and they're becoming more popular and we're using them more often. So I'll just show an example of one study done with GLP agonists. This is called the Lira Ramadan study using liraglutide, Victoza. So this is a study compared to liraglutide. Again, is a standard treatment of sulfonylureas. So this is in patients with type 2 diabetes in Ramadan. And they did both because obviously they want to assess glycemic control. So they did fructosamine and they did hemoglobin A1C. But fructosamine sometimes helpful because it gives you short-term glycemic control. So when they did the fructosamine, there was no difference between liraglutide and the sulfonylureas in terms of fructosamine levels. However, when they looked at the composite endpoint, looking at people who had hemoglobin A1C less than 7%, plus no weight gain, plus no hypoglycemia, there was a lot of benefit from liraglutide compared to the sulfonylureas. In fact, almost 3 times better outcome with the GLP agonist compared with the sulfonylurea. So in terms of glycemic control and less hypoglycemia and less weight gain, these drugs are better than sulfonylureas. So the patients in the liraglutide group demonstrated better weight control and fewer confirmed hypoglycemic episodes compared with the sulfonylurea. So as a result of that, this is a DAR guidance about the GLP agonists. So they say as long as their dose titrated before Ramadan, and they mentioned the GLP agonists that have been actually tested in Ramadan. So that's liraglutide, lexasenatide, exenatide. As long as they have been appropriately dose titrated before Ramadan, at least about 2 to 4 weeks at least, then no further treatment modifications is needed in Ramadan, and they can be used in Ramadan. GI side effects are important, and this is just a study. This is just to show 2 studies to show that you get nausea at the start when you start using these drugs. So, but usually nausea settles in about between 8 to 12 weeks time. So as Dr. Khadija mentioned earlier, if you are going to use these drugs, they need to be started and titrated well before Ramadan so that to avoid the GI side effects. By the time you are in Ramadan, you should have already reached a stable dose and the GI side effects should have settled. And it's not a good idea to start them just before Ramadan because you could get nausea, and that's not good for the patients who are going to fast. And very recently, we've had some additions to the GLP family, GLP agonist family. We have now an oral GLP agonist, that's oral semaglutide or Rybelsus. And very recently, from last October or so, we have had another new addition, tirzepatide or Mounjaro, and this time it's actually a dual GLP-GIP agonist called Mounjaro, becoming very popular. We started using it from last October, and we have a good number of people who are taking it now. Generally, it's felt that they will probably be similar to the other GLP agonists. Obviously, no studies have been done in Ramadan, but they are considered similar to the other GLP agonists. In case of the oral semaglutide, because this drug has special conditions of taking it, because it has to be taken on the stomach and has not been tested in Ramadan before, a group of experts are together trying to produce guidelines about using it in Ramadan. This is consensus opinion. And basically what they said, given the lack of current published evidence for the effect of oral semaglutide during Ramadan, a panel of experts formulated recommendations for administering oral semaglutide in Ramadan. So what they recommended was, first of all, similar to the other GLP agonists, it should be initiated at least 6 to 8 weeks prior to Ramadan to reach an effective dose, which is 7 milligrams. There are 3 doses, 3, 7, and 14. 3 is a starting dose, and 7 and 14 are effective doses. So at least should reach 7 well before Ramadan. And avoid titrating the dose or escalating within the 2 to 4 weeks before Ramadan. Patients who are already receiving oral semaglutide, they should remain on the same dose, either 7 or 14. We should not escalate it during Ramadan because of the risk of GI side effects. And as I mentioned, it has to be taken on empty stomach. So the recommendation is it should be taken at, if you're going to take it in Ramadan, you should take it at the time of iftar, azan time, with water and not eat. So go and pray Maghrib and wait 30 minutes before starting iftar. Okay, so this is a condition to allow for proper absorption of this drug, because there has to be 30 minutes before taking a meal. So to summarize, really the advice on adjusting medications, really the key word is individualization. Every patient is different from the other. We should talk to the patient, take details, and then advise them accordingly. With making the change in the dose and the timing of the medications, we can avoid hypoglycemia, which is obviously the most feared complication from fasting. But at the same time, we want to avoid hypoglycemia, but we don't want the diabetes control to deteriorate during Ramadan. It's generally preferred to use the medications with low risk of hypoglycemia, like the incretin drugs, DPP-4, GLP agonists, and also GLP-2 inhibitors, the drugs that don't cause hypoglycemia, and of course metformin. So these are preferred in Ramadan. Overall, I think if we provide the proper education, if we give them good support from health professionals, I think many people can actually fast quite safely with very minimal risk of complications from fasting. And I'll stop here. I don't know if we can take 1 or 2 questions before we go to Dr. Khadija.